takes hours to finish because it is usually, the idea is that it should be interactive. But anyway, I'm gonna try and squeeze it in 40 minutes. So the approach for the talk about childhood epilepsy syndromes, there are different ways of doing that, but practically and clinically the best way, I think, is to take it by age, because at each age there are different kinds of presentations. And during the talk, we're gonna speak about the different kinds of epilepsy. We have some videos. So the objective is that we wanted pediatricians to be familiar with the common pediatric epilepsy syndromes that might encounter. And like I said, we're gonna start with the neonates. In the neonates, I'll start with something called benign neonatal convulsions. There is no clear etiology for it. And usually there's some gene mutation like potassium channel, some CSF zinc deficiency.
Recording in progress.
Oh, so in benign neonatal convulsions, the neonate is healthy. It's very important when you examine the baby looks healthy neurologically and generally. And this is a self-limited type of seizures. Usually there is no family history of seizures. As in anything in neonates, everything presents as apnea. So differential diagnosis of apnea in a neonate includes seizures beside hemorrhage, infection, etc. Now, when you do the EEG, in neonates, we more focus more on the background, the EEG background. If the background is normal, then that favors such a diagnosis. Everything you do is going to be normal. MRI, CSF examination.
Abdalla, can you maximize the screen? Put it in presentation mode, please.
I thought I did, but just 1 second. So let me just.
Okay, you can continue, Abdalla. It's okay.
Continue. Okay, it's fine. Yeah, that's good.
Is that okay? Huh?
It's okay.
Yes, it's okay.
It's okay.
So I have to go back a little bit. Is that okay? Huh?
Yeah, to me it's fine. I don't know as a candidate. Is this fine? Any problem in the screen?
They are asking to maximize the screen.
They're asking, yeah, I see. Then someone asked about also.
Maybe if I take the.
That's fine, Dr. Abdalla, you can continue. Just for sake of time, you continue.
Yeah.
Let me see like that. I don't know whether that make a difference.
Yeah, it's fine.
Okay, so this is benign neonatal convulsions, okay? And the next one is benign familial. Remember, this is benign familial. Before it is benign neonatal. There is no family history. This one here, there's a family history. Again, it's a healthy neonate, but if you ask the mother, you will find many kids in the family who had seizures in the neonatal period. Again, these are somal dominant, by the way, benign familial. And again, there is a voltage gated channelopathies like potassium channel KCNQ2, KCNQ3, and rarely sodium channel CN2A. Again, the seizures as in a neonates, either apnea or focal or multifocal, tonic or clonic or tonic chronic. We're going to talk about that as we go through. There is no other neurological abnormalities. The baby is healthy. The seizure typically continue for days or weeks, usually brief and resolve spontaneously. The EEG is also normal, okay? Well, there is some, in the past, we used to say these are normal kids, but as they grow up, usually there are some neuropsychological problems as they grow. Then there is something called early myoclonic encephalopathy. Now we are going into a baby who is not normal on examination, and he has seizures, okay? It's usually, again, multifocal, either myoclonic jerks or tonic or focal tonic seizures. Now, the baby is encephalopathic, meaning he is drowsy, he doesn't feed well, he doesn't move well, and then you do the EEG, it's gonna be abnormal. Like I said, we always focus on the background. Remember, this early myoclonic encephalopathy, EME, is usually associated with inborn error of metabolisms. So we have to investigate for that. Example, non-ketotic hyperglycemia, organic acidemias, urea cycle defects, peroxisomal disorders, like Zellweger, like adenyleukodystrophy, molybdenum cofactor deficiency, GLUT1 deficiency, maple syrup urine disease. So there is a metabolic abnormality when you have this kind of seizures in a baby who is not normal. And of course, the prognosis is linked to the underlying condition. There is something called birth suppression. So this is an example of a birth suppression. This is there is a suppression here pattern. You see there is no waves or small kind of few waves, and then suddenly you have a burst of very high voltage waves, and then a suppression, and then a burst, and then a suppression. When you see that in a unit, that is definitely not a good sign. You see that with this kind of seizures, and then example for that, I'm not gonna take much time on it, but there's something called pyridoxine-dependent epilepsy. Okay, it's an autosomal dominant condition. And again, whenever you have a baby who's encephalopathic and having seizures, you have to think of that. So the EEG burst suppression, and it might go into infantile spasm. We're gonna talk about that later on. There are certain metabolic tests you do, plasma hypochlorous acid in the urine and CSF. Also you do CSF ASA. And the treatment, we give pyridoxine, 100 milligram, and usually we do it while the EEG is running, because you're gonna see immediate reversal of the EEG pattern while you are giving the injection. And then we give 100, and then we could keep going up to 500. And then once improved, you're gonna treat them with pyridoxine. If you suspect that and still there is no response, there is something called pyridoxamine 5-phosphate oxidase deficiency. Resistant to pyridoxine, but responsive to pyridoxamine phosphate. Again, the baby is usually preterm, with hypoglycemia, and the seizure is similar, either tonic, myoclonic, usually focal, because I mean, the white matter is not completely mature in the unit, as you know, and the EEG is also showing as a burst suppression pattern. The treatment is oral pyridoxal phosphate. If you do that and still no improvement and you strongly suspect metabolic, these are the treatable conditions. It's very important you remember them because these are treatable conditions. There's something called folinic acid responsive seizure. Now, if you, the pyridoxine deficiency, pyridoxal phosphate deficiency, and then you go into folinic acid, in these cases, again, they will not be responsive to anti-epileptic medication or pyridoxine or pyridoxamine. But we give them folinic acid, and usually if we suspect that, we give it empirically, 3 to 5 milligram per kg. And of course, there is a genetical determination, mutation in the ATQ. If you don't treat it, it is fatal, and or the child will go into severe neurodevelopmental regression. Another example, something called glucose transporter 1 deficiency, GLUT1, detect the defect in the blood-brain barrier, passive transport of glucose. You do it, we do a spinal tap, the CSF glucose is very low in comparison to the blood glucose. The baby may appear normal at birth, but usually they are encephalopathic. Again, the presentation is similar, focal motor seizures. Again, there is family history. If you take family history, you might find some family history of what we call paroxysmal exercise-induced dyskinesia in some families. I'm going to skip that for the sake of time. This is an example for a burst suppression pattern, like I told you. The burst itself is very abnormal, spike and wave discharges, and in between you see the suppression pattern. This is a very bad sign in a unit. Then we move on to something called Dravet syndrome. I don't know whether we heard about it or not. This is, we are going into an older child. Typically, the first seizure is febrile. Now, always I tell the residents, whenever a child presents with this status epilepticus febrile, somebody had a febrile seizure that lasts more than 15, 20 minutes, this is not your usual febrile seizure. And you have to be alert to that condition because it might end up being one of those syndromes. The Dravet syndrome, like I said, the typical first seizure is febrile, either complex or prolonged. At the beginning, the baby is healthy, but as you grow, you're going to see developmental regression. So the myoclonic seizures, the jerks, appears after the first year of life, even though we call it severe myoclonic epilepsy of infancy, but usually the presentation is generalized tonic-clonic seizure linked with fever. And the EEG showed a spike and wave discharges. There is a family history of seizure in about 20% of cases. And of course, genetic testing is empirical in this case. In 80% of cases of the Dravet syndrome, there is a mutation in the sodium 1A gene. Now, because it is a sodium channelopathy, we always avoid using medications that are actually work through the same mechanism. So you avoid Tegretol, avoid Lamictal, and you could use valproic acid, which is Epilem or Depakote, topiramate, clobazam. Now, cannabis or cannabinoids, people are adding it. Resistant seizures, especially with benzos like clobazam in cases with Dravet syndrome. But all of the thing I wanted to take off is whenever the febrile seizure is atypical, especially prolonged or recurrent, you have to think of this kind of diseases. Remember, the baby at the beginning would be healthy and normal. As you grow up, you're going to start developmental regression. We are still in infancy. I don't know whether there is time, but I'm going to show you this kind of seizures in Dravet syndrome. You see it's focal, you see the left upper extremity shaking. For the sake of time, I'm going to move on to infantile spasms. So infantile spasm, as the name implied, it occurs in infancy, and usually it is the latter 6 months of infancy. The infancy is, as you know, from the neonatal period after 28 days until the first year. But usually, typically after the age of 5 or 6 months. If you see infantile spasms in a baby who is 2 or 3 months, this is serious. Or a baby who graduate of other kind of neonatal encephalopathy. But usually it occurs after the age of 4 to 7 years. So it is a rapid flexion or extension of the neck and trunk, usually the head, either forward flexion or backwards. And this number one. Number two, they occur in clusters. Remember that. They occur in clusters. You would see 4, 5, 6, 7 of these episodes, one after another, one after another. This is called a cluster. So you have more than one cluster per day, okay? And usually you see it commonly during drowsiness or soon after waking or during feeding, okay? Now, in the past, we used to classify them for the sake of treatment into symptomatic and cryptogenic. The symptomatic means there is an underlying neurologic disease. This could be structural abnormality, could be a progressive neurologic disease. Most common is a neurocutaneous syndrome, especially tuberous sclerosis. I'm going to show you some picture of infantile, a video of infantile spasm. And then the EEG is classic for what we call hysterismia. And hysterismia, remember I talked about the base in the EEG. This hysterismia is a very chaotic, very high voltage. You will recognize when you see it, or a burst suppression at the beginning. One of the syndromes known to be associated with infantile spasms beside tuberous sclerosis, Down syndrome are more prone to Aicardi syndrome. We can talk about that later on if somebody asks a question about it, just for the sake of time. The mainstay of treatment in the past is to give ACTH for symptomatic infantile spasms or vigabatrin. Nowadays, with the most recent studies, number one, we switch from giving ACTH because it's very expensive. And the recent studies showed that if you give oral prednisone, you achieve the same results. Again, in the past, still some neurologists give either one of them. Nowadays, we give them both. We give both. This is my school. We give both steroids and vigabatrin. Steroid use it for a couple of months, 3 months, 2 months, and then you continue with vigabatrin for another 5 or 6 months. By definition, infantile spasms, it is in the infant period. It might continue for the next year, but as the child grows, you're going to see different kinds of seizures. Now, this is, you're going to look at the head of this baby in a second, and his hands and arms. See that? That's typical of infantile spasm, and it comes in clusters, remember, one after another. If you see it, you won't miss it. That's another one. That's the third one. And this one, I don't.
Clip shows a child with a typical full house with flexion, extension, and flexion once again, with no particular distress. This second clip shows a typical flexor spasm with distress in between spasms, ceased abruptly by a further spasm, the spasms occurring in clusters. The next 2 videos show more subtle spasms occurring in older children. The first clip shows a child with only a slight head nod as part of the whole seizure episode. In the 4th child, the episodes are even more subtle, involving part of the face, upper limbs, or even just the hands.
I'm going to move on for the sake of time. So this is what I call hysterismia. If you look at this, it's a very chaotic record, and it's very high voltage, very disorganized. Infantile spasm could be generalized, like in this case. Sometimes it could be hemispheric. You see it on one side. But that is, when you see this, this is diagnostic for infantile spasms. Now there is a condition called Dew's syndrome, myoclonic aesthetic epilepsy. I'm gonna take this opportunity when I show you the video to see what we call generalized epilepsy, either generalized tonic-clonic, generalized tonic, or generalized clonic, shaking, or atonic, which is drop attacks, or myoclonics with sudden jerks. All of them could occur in a child with Dew's syndrome. Just like Dravet syndrome, the child at the beginning might appear normal. Now, the first seizure is usually generalized tonic-clonic, with or without fever. That's the difference between it and Dravet syndrome. The range is from 6 months to 6 years, and average is 3 years. Boys are affected twice more than girls, and the classic seizure is myoclonic, followed by atonic, which is drop attack. But generalized tonic-clonic seizures and absence seizure, what we used to call it petit mal seizures, used to occur. Usually it occurs in older children. But if you see absent seizures in a child who is 1 year or 2 years old, this is very serious. Because when we talk about absence seizure, typical classic absence seizures, usually after the age of 4. And we're gonna, if you have time, we're gonna talk about it. Now, the EEG at the beginning is normal, remember, with DUS syndrome. But as the child grows, you start seeing all kinds of discharges. And MRI is normal, and the seizures are difficult to treat. Again, there are different genetic mutations. Some of them sodium channelopathies, as something called SLC6A1 in 5% of cases. And again, just like in Dravet syndrome, you avoid carbamazepine, oxycarbazine, phenytoin, and vigabatrin. Ketogenic diet sometimes is helpful, and so is a vagus nerve stimulator. We're going to move on. I'm going to show you. This is a mother recording her baby, and she emphasized how the baby was normal early on, and then suddenly it hits him at one stage. Again, for the sake of time, this is started with generalized tonic-clonic seizures. I'm going to move on. I wish I had more time to show you the full video and talk about it. Lennox-Gastaut syndrome, these are usually graduates of kids who have infantile spasms, underlying structural or genetic abnormalities. Triad, we see that severe cognitive impairment and the typical EEG findings, which is usually what you call 1.5 to 2.5 hertz per second. If you see in absence seizure, we call it 3 hertz per second. If I have time, I'll explain that on the EEG. Usually, again, the age between 2 years to 5 years. Kids who had hypoxic ischemic encephalopathy, structural abnormalities, like I said, and again, difficult to treat. Yeah. We're going to move on. Ketogenic diet is very helpful in these patients. I'm going to move on here. So this is the Lennox-Gastaut syndrome. It either slowing, like the first section here, just generalized slowing, I see. And the second one here, it is not 3. This is a spike and wave, and then 2.5. You could say 2.5. It's not typically 3. 1, 2, and probably a half. 2.5. 1.5 to 2.5 hertz. From here to here is 1 second. Okay, we're going to move on. Benign rolandic epilepsy. You see this as a pediatrician commoner than the others. Again, this is toddlers between the age of 3 to 13 years old. Peak is 5 to 8 years old. A strong family history of epilepsy. And it resolved spontaneously by 13, 14 years old. In the past, we used to call them benign, but actually we found out you see other neurocognitive problems, ADHD, hyperactivity, other kind of some mild cognitive deficits. The seizure typically occur either when you are going to sleep or you're about to wake up. And the beginning is focal. Usually the mother will tell you, we hear the gurgle sound, it is oral facial. We hear the gurgle sound from his room, and when they go inside, they see the seizure becomes secondary generalized, both sides. But it begins focal in the face, hemifacial, and then they respond well to treatment, and the EEG is typical. called centrotemporal spikes, usually unilateral, but it could be bilateral. And they respond well to most of the anti-epileptic medication. This is, look at her face, because it's usually oral facial. See the drooling? I don't know if they'll be able to see it or not. Drooling from one side. See that from the right side. I'm going to move on. This is what I say. These are the central leads here. Central temporal. T is for temporal, and C is for central. And you see the spikes here. And you see them more as the patient drowses. These are the temporal lobes. See some more frontal temporal. You don't see much, but you see it here more frequent. As the patient goes into stage 2 sleep, you see more of them. For the sake of time.
Still you have 15 minutes, or Abdullah, you have 15 minutes. Okay, still.
I still have 15 minutes?
Yes.
So, okay, then I don't need to rush. I mean, I said I could give this presentation in 3 hours, I could give it in 1 hour. But this is another, again, I said oral facial. You're going to see some drooling coming from the left side this time. Okay, and then the whole whole left side is going to be twitching, then it extends to the arm and leg, and then it becomes generalized. So there is a similar condition, we call it occipital epilepsy. Again, it's benign, actually more benign than the benign focal epilepsy or rolandic epilepsy. The syndrome was named after a Greek guy. So they call it Panayotopoulos syndrome. Similar age, 3 to 10 years more in boys. Similarly, seizures start focally, mostly during sleep. But remember this line, nausea and vomiting. If you see the typical seizures, typical age, and then you see the muscle tell you he had nausea or he vomited before or after, you think of Panayotopoulos syndrome. And then when you do the EEG, the discharge is, instead of being central or temporal or parietal, is going to be occipital. Okay, it could usually focal, but it might be by occipital. This is actually had a better prognosis than benign rolandic epilepsy, because usually it is not associated with future neurocognitive problems. For the sake of time, I'm going to skip this video. Let us see what is here. Oh, I'll go into Landau-Kleffner syndrome. We'll move on. Landau-Kleffner syndrome, remember, that is a baby who was growing normal, and then suddenly he started having regression. Mother will tell you he started saying single words when he or she was 1 year old or 13 months old, or even 18 months old. He started talking, and then they lost it. So they regressed, okay? Again, the same thing with the cognitive development. It was normal at the beginning, then you lose it. Remember this, developmental regression. That is the key word here for Landau-Kleffner. Both Landau and Kleffner were neurologists at St. Louis Children's Hospital, where I did my pediatric residencies there. And they are the ones, they were meeting in the elevator and they were discussing these cases, and they came out with this syndrome. Speech regression, difficulty understanding mainly expressive, or they could stop talking. And then you will see some behavioral problems, hyperactivity, pervasive developmental disorders, and various types of seizures, either generalized or focal. Some of these types are associated with what we call continuous spike and wave discharges during slow wave sleep. Continuous spike and wave discharges during slow wave sleep. Developmentalists usually seen by developmentalists because of the speech regression. They might not have seizures at the beginning, so they send it to the neurologist for EEG. Oftentimes, you do the EEG, the usual EEG, which is 45 minutes, 1 hour EEG. It might be normal. Usually when they come to me with a clear history of speech regression, I usually wanted a more continuous 24-hour EEG because I need to capture the slow waves. I mean, we don't have time to talk about EEG, but the sleep stages, there is a REM sleep and non-REM sleep. The non-REM sleep is stage 1, where the patient just drowses. Stage 2, marked by spindles in the EEG. These are, I mean, if you are in stage 2 and you hear the loud voice, you will wake up. But once you go into stage 3 and 4, these are deep sleep, where the waves become very slow. We call it delta waves. Now, in those Landau-Kleffner syndromes, you needed to capture a deep sleep. The only way you do that is you bring him into the hospital overnight while recording. You're going to see runs of spike and wave discharges while the awake EEG was normal. That's why we admit them to the hospital. If you treat, even if you don't have, we have patients who never have seizures, you treat them with steroids or with valproic acid, and you might be able to reverse the regression in the speech, reversal of the aphasia. Very interesting. So remember, you might have seizures, you might not. Eventually, you might have seizures. But the main thing is the speech regression. Move on. Partial seizures, they occur at any age. Remember, my talk is about age, but the partial seizures occur at any age. The old classification, we say this is simple or complex. Simple means you would have the seizure while you might be able to communicate, or often they will tell you, I heard everybody talking, but I wasn't able to talk. The complex means there is a loss of consciousness. That's one thing to remember. Not all seizures are associated with loss of consciousness. So simple partial seizures, usually the patient is awake or semi-awake. Another thing to remember, there is something called aura. An aura means something happened before the onset of the seizure. You might have aura alone, or it might progress into a focal seizure. And the aura could be visual, could be auditory, could be sensory, could be psychic, auto seizures like abdominal pain, smelling something, hearing something, and then it goes on. There's something called the deja vu phenomenon, or deja vu, where you deny recognition of places you are familiar with, and vice versa in the gamma vu. The seizure is focal. Could be arrest, oral automatism, or hand automatism. Oral means like lip smacking, movements of the tongue, movements of the mouth. Hand automatisms, that could be the whole thing. And then it might progress into a focal seizure, one-sided only. Focal seizure always can progress into generalized as the wave spreads through the other cortex. The EEG would show the focality of the nature. Whenever you have focal findings in the EEG, you have to do an MRI of the brain because it could be symptomatic, meaning there is an underlying structural abnormality, either a tumor, kind of cortical dysplasia, some old neonatal insult, infection as a cause. And in the past, we used Tegretol, carbamazepine as a first line. Nowadays, we use oxycarbazepine, which is trileptal, which had a better side effect profile. Valproic acid can be used for both generalized and focal epilepsy. Keppra, pediatricians use Keppra a lot. It's kind of a newer medication, which is levetiracetam, we call it. It is newer with fewer side effects. It does not affect the major systems. It does not, meaning it does not affect the CNS, the kidneys, the liver, like the other drugs. Kids sometimes have some behavioral problems with it. We usually add vitamin B6 with some success, but generally speaking, is well tolerated. So this is partial seizure, and this is the EEG. If you see here, F means frontal, C means cortical. The odd numbers are for the left, and the even numbers are for the right, like P4, this is right parietal, O2 is the right occipital, and so on and so forth. So if you see here, this is frontal left, and this is, so you see the discharges are here. So this seizure is coming from the left frontal region, okay? Now, childhood absence seizures, again, the age is between 4 and 10 years old. Remember, if somebody or a mother comes to you, her child is 2 years old or 1 year old, and he had staring or zoning out episodes, and then you do the EEG is abnormal, that is an ominous sign. This means this is not your typical classic absence epilepsy. I would say more than 80, 85, 90% of cases of childhood absence seizures, they grow out of it without complications. Few of them will go on to develop what we call juvenile absence epilepsy, where they develop other kinds of generalized seizures. Absence is part of the generalized seizure syndrome, okay? It can be familial in 15 to 40% of cases. Usually the child will be playing and then suddenly stop the activity and stare in the space for 10, 15 seconds. There is no aura. That's the difference between the staring of complex partial seizures and the staring episodes you see it with absence seizures. There is no aura and there is no post-ictal phase. Usually with complex partial seizure, the child after the seizure is over will be very tired, exhausted, headache, sometimes vomiting, wanting to sleep. With absence seizures, they are very frequent and they are very brief, and the child, when the seizure is over, would go back to his or her normal activity as if nothing happened. Rarely you could go into absence status, continue all the time. The EEG is classic, you call it 3 hertz per second. I think I talked about it earlier, but I'm going to show you example now. The interictal EEG is usually normal. Another thing, you could trigger the absence seizure in your office by hyperventilation, because this kind of seizure triggered by hyperventilation. Usually I will hold the paper in front of me and ask the child to hold the paper, and both of us will be blowing for 3 minutes. Okay, and while you are blowing, you tell the child that when I say a color, for example, when I say green, you say green. When I say yellow, you say yellow. And then you start blowing. And then suddenly you say yellow. If he had the absence, he would not say it. So that's one way of doing it in the office if you don't have EEG. I don't know whether...
Dr. Abdallah, we have only 3 minutes left and we have few questions in the chat box.
So I'm going to, one last thing is juvenile myoclonic epilepsy. This is a kind of a seizure occurs in juvenile kids, usually spike and polyspikes triggered by photic stimulation, generalized epilepsy. What else can I tell you? The EEG is also typical, and unfortunately, they will continue having seizure for the rest of their lives. But the good news is usually they are responsive to treatment. I don't know if there is time to talk about this. It has 2 components, the generalized epilepsy component and the jerks, yes? I just want to show you something here, the myoclonic jerks, and then we will wrap it up. So this is a patient with juvenile myoclonic epilepsy.
Yeah, I'm fine. I just don't have anything else.
And
Thank you.
Epilepsy Society, supporting everyone affected by it.
So this is the type of the EEG on juvenile myoclonic epilepsy. You see the polyspikes. I'm going to wrap it here. And
okay, thank you
maybe
very much.
Yeah.
Excellent talk. We have few questions before we wrap. Few questions in the chat box.
Yeah. Dr. Mudasir,
Yes.
Yeah, one of the question, Dr. Abdullah, one of the candidates asking when to start anti-epileptic medication. Is it after first unprovoked seizure or would I should wait for second attack?
That's a good question, actually. Usually, with the most neurologists, with the first attack, we don't treat, but that's a general talk. So if you have somebody with an episode and then you do the EEG, and the EEG is really abnormal, suggesting of a specific syndrome like absence or like benign focal, if the EEG tells you this is epilepsy, then I might start from the beginning. But the general rule, especially with something like complex partial seizures, which was the first seizure, you do the workup and and then wait for the second seizure.
Okay. Dr. Mudassir, can we respond to another question? Or, I mean, one of the last question, Dr. Abdullah, one of the candidate also, she's asking about the West syndrome, use of ACTH or vigabatrin at the same time, and what is the best?
See, I know that Mudassir and Dr. Oshi, you are familiar with the latest studies,
Yes,
the British one. Yeah, which is because the ACTH was so expensive. I mean, one company actually.
It's not available.
In the US, it's available, but it's $10,000 for one shot. So that's why it prompted the epileptologist to do the study. And the study proved that giving oral steroids is as good as giving the ACTH. Now, the second question, whether you usually somebody like tuberous sclerosis is known, you use vigabatrin as the first line. But generally speaking, my practice, infantile spasms, actually I use both. This is the only type of seizures where you are treating actually the EEG. You are treating the hypsarrhythmia. Even if you control the clinical seizures, the EEG is still showing hypsarrhythmia. It is known that it's a crime if you don't treat it, because you're going to end up with more severe developmental regression. So that's why you have to hit hard.
Yeah, thank you, Dr. Abdullah, for your very nice talk. Actually, we all learned a lot from your talk. I mean, for your comprehensive summary for epilepsy syndrome.